And thank you for that last question, because it allows me to say that, as Dr. K has indicated, the Foundation is now leading a worldwide effort to develop and publish guidelines for the diagnosis, treatment, and management of IgG4-related disease. And these will be completed by October of 2026, a little bit more than a year from now, at the time of the 6th International Symposium. So that's a great question. We're also off to a great start because we've had fantastic questions. And any kind of question about anything related to IgG4-related disease is welcome. So this is a breakout session. And breakout sessions were a hugely popular part of the first JAM in Tyson's Corner in Virginia. And we thought we would offer even more breakout sessions for this PeachJAM. So what is a breakout session, since this is the first JAM that some of you have attended? A breakout session is something that rheumatologists and other doctors do when they go to their subspecialty meetings. They break into smaller groups, and there is an expert leading a discussion about a certain topic. And the idea is that that expert gives a few remarks about the topic to be covered, but it's not a lecture. So I'm not going to talk for 45 minutes. I'm going to say a few words about side effects and some other things. And then we'll open the mics. And you can ask a question about anything that you want. The topic of this breakout session is avoiding the potential side effects of treatment. And the reason we're not breaking out into smaller groups for this one is that there was a lot of interest in hearing about the side effects, potential side effects of therapy. So we thought we would keep the whole group together for this. But then you'll break off and you can go to any breakout session that you would like to go to. I will start coming back again to this concept of ignorance. We are all ignorant, just on different subjects. And this is a famous quotation attributed to many people, from Abraham Lincoln to Winston Churchill and probably others, but I think it's most rightly attributed to Will Rogers, who was an American humorist. So this is a way of saying, don't be afraid to ask a question. And we've already had great questions. So I'm going to start by reading you a poem and telling you briefly about a patient, and then I'm going to focus my remarks on B-cell depletion, which is the therapy of the day now with the first FDA-approved treatment. There are lots of different treatments that I could talk about, but the intention, again, is not to give a lecture, but just to kick off the questions. And then preparing to prevent side effects. So the poem is called Helping with the Math Homework. And the poem was written about me. And it was written by my father. I said I'm an Atlantan, and my father was a physician. He, like Dr. K, was a professor of medicine at Emory. And I was a faculty brat in college. And he was a cardiologist, and he was, but in addition to being a wonderful clinician, and he was my first role model, my greatest role model as a clinician, he was a writer, and he wrote several books of poetry, and he was a very good writer. And he was a pretty good soccer coach, too. When I found at the age of 13, for me, that life had been pretty easy for me up until that point. I had done pretty well in school. I was a pretty good soccer player. And then I ran headlong into geometry. And I found that Dad was not a good math teacher. And he wrote this poem, which kind of summarizes our struggles, the struggles that we both had in his trying to help me with my math homework. I have to give you a little bit of background. It's a short poem, but it'll help to give a little bit of background. So it's about geometry, and the key part of this figure, which I downloaded from the internet, is the triangle with three sides, A, B, and C. It's a right triangle. And there was a Greek named Pythagoras who came up with the Pythagorean theorem that a squared plus b squared equals c squared in length. And geometry got worse for me from there, because after squares it got into cubes, and x cubed minus y cubed figures in the poem. Trial and error. This was an approach to trying to figure out geometry problems, I think. You just sort of took your first best intuitive guess. If that didn't work, you tried something else. It never worked very well for me. This was all part of the new math, which was an idea forced down the throats of American students in the 1970s that I think has been thrown on the scrap heap of educational projects. And then the back of the book, a line from the poem, the back of the book held the answers to the odd-numbered problems, not the even-numbered problems, the odd-numbered problems. And so the tendency, the trap which I fell into, was to try the odd-numbered problems, not very hard, and then flip quickly to the back of the book and see if I'd gotten the right answer. And I didn't get the right answer most of the time. And I said, Dad, the back of the book says this, and and one of the lessons that I learned is that you have to agonize over certain problems, to get to the right answer. You can't just assume you're going to get to the right answer quickly. You have to agonize over it. So that's a little bit of background for the poem. Helping with the math homework. In the beginning, there were polynomials, differences of squares, trial and error, and the sum of two cubes. X cubed minus y cubed has always had the same meaning, whatever it is. But when Pythagoras looked into the eye of the triangle and saw the solution, I wasn't there. Nor have I ever found anything more than safety in numbers. This is the new math. These are your problems, and I was born before the back of the book. What I have been saying is this: I can lead you only so far into wisdom. Soon you must begin to learn how to be ignorant on your own. So that is a good way, I think, to start a breakout session. We are, a couple of decades into a disease, and the disease was not known at all. There's still a great deal of ignorance in the world about this. Nobody has the answers, including the experts who are here. So we're all learning together. I've talked about ignorance a lot. Ignorance is not what we want to emphasize here at the PeachJAM. It's enlightenment. Again, this painting by Monk. So the patient, Ms. H, whom is a 34-year-old woman whom I met for the first time about 6 weeks ago, she presented with back pain and swelling in both of her legs. This was in 2017, and she was found to have reduced kidney function. She was diagnosed as having hydronephrosis, where the urine backs up into the kidneys. Many of you will recognize that, having had it yourself. And she had bilateral stents placed into her ureter. She had a biopsy which excluded cancer, and she was diagnosed with retroperitoneal fibrosis. The link was not really made between retroperitoneal fibrosis and IgG4-related disease, and she was treated with prednisone. And she's been on prednisone ever since 2017. After 5 years of prednisone, her doctors got around to ordering an IgG4 level, and it was high, not surprisingly. And on examination, when I saw her, she had a moon face from steroids. She was hypertensive from steroids. She had thin, easily bruised skin. And she had had a bone mineral density study that demonstrated that at the age of 34, she had osteoporosis already. So that's the patient, and we'll come back to her and how I think she's going to do with treatment. But there are two treatments that unquestionably work for IgG4-related disease. The first is steroids. Steroids work. They control the disease. They controlled her disease. Her stents were able to come out. but they didn't cure her disease. She had to be on between 10 and 15 milligrams of prednisone a day for 8 years until I met her. And the second treatment that works is B-cell depletion. So I'm going to talk about B-cell directed therapies, really just B-cell depletion. So there are 2 monoclonal antibodies that are used. There is one that is approved by the FDA for the treatment of IgG4-related disease, inebilizumab Uplizna. So we'll talk mostly about that. There are some other new therapies on the horizon. They're all targeting B cells, essentially. Obexelimab suppresses B cells. It doesn't deplete them. ACE 1831 is a B-cell depleting therapy. It is a cell-based treatment. And rilzabrutinib is a B-cell modulation therapy. Again, it doesn't deplete B cells. But the dominant game in town really is B-cell depletion with INEB now. It's the only approved therapy. So what do I tell patients about B-cell depletion? I tell them, and I can do so because I feel this very deeply, that these drugs are safer and more effective than steroids and the group of drugs we call DMARDs, disease-modifying anti-rheumatic drugs, drugs like Cellcept, methotrexate, etc. B-cell depletion is more effective and safer on the whole than those other therapies. So let me give you just a little bit of background about the B-cell, and we are, as I'm announcing also, we will have a fireside chat about everything you ever wanted to know about B-cells but were afraid to ask in December. So stay tuned for that. But a little bit about B cells now. So B cells are a very important cell in the immune system, and they all have 2 markers at some point in their development on their surface. One is CD19. It's a protein that protrudes from the cell surface. The other is CD20. CD19 is the target of inebilizumab. CD20 is the target of rituximab. So all of our B cells have these proteins on their surfaces. Just a little bit about B cell development. B cells come from stem cells in our bone marrow, so down here, and very early on in their development, they start to express on their cell surface CD19. There's a positive sign there. So that's this pro-B cell has CD19. It still doesn't have CD20. And then at the pre-B cell stage, CD20 is also present. After developing early in the bone marrow, within the inner parts of our long bones, the B cells move out of the bone marrow, and they move into lymph nodes, where they continue their development, becoming mature B cells, learning to do what B cells do, which are a number of things, but they make antibodies, including IgG4. And they go through through a number of stages. They have CD19 and CD20 from the pre-B cell stage all the way through the memory B cell stage, and then at the plasmablast stage, they lose CD20, they still have CD19, and they go back to the bone marrow as plasma cells. Some of them still have CD19 then, and they live for a long time in the bone marrow, continuing making the antibodies that they learn to make in the periphery. Now, when you give a treatment that depletes B cells, you deplete all of these cells. If you give, and in fact, you deplete the pro-B cell too, if you are treating a patient with inebilizumab. So what does that mean practically? What does B cell mean practically? So B cells having CD19 or CD20 are percolating around in the blood, and they're in lymph nodes, and they're doing what they do all the time, which is mature into plasmablasts, which produce IgG4 and other antibodies. And these plasmablasts go away. They're very short-lived. They make their antibodies for a while and then they go away. That's okay because the B cell pool is still there intact and it makes more plasmablasts. So the level of antibodies, including IgG4, remains stable. But if the patient is treated with INEB, the B cell goes away, and then there's nothing to replenish this plasmablast pool, and the IgG4 level falls, and other antibody levels fall as well. For a while, we thought that that was the essence of IgG4-related disease, that B cells told the whole tune. We now know that other cells are important too. B cells are the most important cell, but they're T cells, and it's a little bit more complicated than I've depicted. But that's really all you need to know when it comes to B cell depletion therapy. So after INEB, B cells are not measurable in the peripheral blood. You can't measure them. But the body is not depleted of B cells entirely, and that's important to know. We wouldn't want to deplete the B cells, the body of B cells entirely. But it's just getting rid of them from the peripheral blood is enough to have a very powerful impact on many diseases, including IgG4-related disease. The body is not completely depleted of B cells because the B cells, they're gone from the peripheral blood, but they reside still in lymph nodes. So this picture depicts a lymph node, and our bodies have lymph node chains throughout the body. So B cells remain in the lymph nodes, and if a person has been vaccinated, for example, before B cell depletion, then the ability to respond to viral infections remains intact because of this persistent immunity generally. Now, after B cell depletion, the B cells recover. They always come back, but they come back at different rates depending on the patient. And complete recovery before 6 months is unusual. It takes many patients a year or longer for the B cells to recover. And during that time, patients are at risk for certain adverse effects. It is remarkable that we can deplete the blood of B cells completely and have the great majority of patients do extremely well. It's really a remarkable thing. But there are some side effects to mention, and I will go over these with you. And these are what I tell a patient before I start a patient on B cell depletion. So there is the chance that reactivation of certain viral infections could happen. Hepatitis B can become reactivated in some patients. Shingles is a big problem. There is a lack of response to vaccines after B cell depletion. So it's very important to get the vaccines done before, whenever possible. There can be infusion reactions during the infusion, which is why we do the infusion typically in an infusion center where there are nurses and nurse practitioners to deal immediately with these if they happen. They can be serious. Anaphylaxis, the throat closes down, and serum sickness. I'll show you a picture of that. They're both rare, but they can happen. And then there are other infections. Some of them can be associated with hypogammaglobulinemia, meaning low antibodies. IgG4 is not the only immunoglobulin to be decreased. Other immunoglobulins can be, and this increases the risk of some kinds of infections. And then there is also an increased risk of infection that goes beyond the hypogammaglobulinemia. Just being B cell depleted can lead to a certain increase in risk of infection. And then there is a neutropenia, low white blood cell count that can occur, and I'll talk about that and give you some more specific details. So let's go through these quickly one by one. Reactivation of hepatitis B. This is not an issue for most patients. Most patients are not at risk for this because they've never had hepatitis B. There are some patients who have antibodies in their blood already, indicating that somehow they acquired hepatitis B, often at birth, and they are at risk for reactivation. But we can prevent that completely. So by having a patient take an antiviral medication while they're B cell depleted. This is 100% preventable. Shingles, a big issue, but it is very preventable, 98% preventable if patients are properly vaccinated. Vaccine responsiveness is diminished in every patient who's had B-cell depletion, and the choreography here is really important. The timing of the vaccine with the timing of the B-cell depletion. You want to vaccinate before, 3 to 4 weeks before B-cell depletion. And in this regard, let me put in an important plug for IgG4 ME, the app that the Foundation has released recently, which helps you keep track of your vaccine history. Nobody can remember when they were vaccinated against smallpox. And it's important to keep a list of this, can be very helpful. So there is no back of the book when it comes to vaccines. And, I say this in all respect for the people who try to develop vaccines and help keep us safe. There's no back of the book. There's no back of the book telling you that these are the flu viruses that are going to be circulating in the population this year, or this is the dreaded pandemic that we're trying to forestall. So with regard to mRNA vaccines, these were 90 to 90% effective in preventing respiratory COVID. I think the authorities made a bit of a mistake when they let it be, the word sort of creep out that these were going to be 100% perfect. There's nothing that's 100% perfect. Even the best vaccines sometimes fails, but these were 90 to 95% effective in preventing respiratory COVID and almost 100% effective in preventing severe disease and death, and they are estimated to have saved 3 million lives in the United States. Unfortunately, as you know, the whole thing has become politicized, but the Foundation, as a source of truth for IgG4-related disease, has to endorse these mRNA vaccines, which are really a medical miracle of our era. So anaphylaxis is very rare, very rare. I've seen one case in about 1,000 patients treated with B-cell depletion. And we do these infusions in an infusion center to guard against that. This is serum sickness. It's frightening looking when it happens, which is rare. I've seen it in one of my patients. It's where the infused, the body makes antibodies to the infused antibody, to the infused drug, and that complex deposits in small blood vessels, causing an arthritis and this rash. It's temporary, the complexes go away, it's very treatable with prednisone. But full disclosure, this can happen in B-cell depletion. So infusion reactions are probably less likely with inebilizumab than with rituximab. The reason I say that is that inebilizumab is a humanized antibody. It's very much like the antibodies that we have naturally. Rituximab is made partially from mouse amino acids, and those mouse parts can sometimes trigger our immune system to make antibodies against the drug. And infections. The overall risk, aside from viral infections, is not quantified well. But there are infections that can occur with hypogammaglobulinemia or without hypogammaglobulinemia. And in this context, I want to acknowledge a member of our advisory board for the foundation, Michael Bamber, who is here with his wife, Linda, who is also an advisory board member. And Michael wrote very compellingly about his experience with an infection following a medical procedure that he had not related to IgG4-related disease. And he became very sick with sepsis very quickly, and it was a very frightening episode. And Michael wrote in one of our good questions that we published, the biggest lesson here is that people living with IgG4-related disease and their caregivers must be vigilant to the possibility of swift changes in their health status and ask questions quickly. A serious drug like rituximab comes with potential risks. And thank you, Michael, for that. It's very, very true. These drugs are wonderful, and they work in the great majority of our patients. I've never seen a patient with IgG4-related disease not respond to B-cell depletion. But they do have potential risks, and they have to be used wisely. So again, these drugs are safer and more effective than steroids and DMARDs. There's just one more side effect that I'm going to mention because it is important, and it probably gets overlooked a lot of times. It's rare, but it's a neutropenia, a low white blood cell count. And I have seen this. I've probably seen it in 5 or 6 patients, and it occurs about at a time when the B cells are repopulating, when the B cells are coming back after being depleted. So it's usually seen about 6 or 7 or 8 months after B cell depletion. And when the B cells are coming back, the bone marrow becomes confused for a while and stops making white blood cells. And for a few days, the patient cannot have any white blood cells. Sounds like a very dangerous thing. It's a little bit dangerous for a little while. Patients can get fevers, neutropenic fevers. There is a brief window, meaning only a few days, when there's a risk of infection, and I've seen shingles occur in that time. Usually by the time physicians realize what's going on, the B cells are already coming back. So it's a very transient risk, but it is important to mention this. Very rare, probably 1 in 200 patients get it. So how will Ms. H do, my patient with retroperitoneal fibrosis? She's going to do extremely well. I am 100% sure of that. We've addressed her vaccine issues before she got treatment. She got a shingles booster and made sure that she was up to date on her vaccines. She's now tapering her prednisone. She's been treated with 2 doses of INEB, and I am going to have her off prednisone in 8 weeks. She's been on prednisone for 8 years, and we're going to get her off in 8 weeks. She will remain in remission for a long time. She may not need to be treated again. She probably will need to be treated again at some point, and we'll have to decide probably through imaging when she should be treated. But she's going to do very well, and she's now asking me about the timing of pregnancy with regard to INEB administration. So that's a whole different conversation, a nice one to be having. So with that, I'll stop. And that's enough of a lecture, and I'll throw the mics open for questions now. Mr. Lowe.
Thank you very much for an incredibly informative lecture. Is it possible to have it printed? Because it has so much information, it's beyond human consumption.
I tried to boil it down, but this will all be available on our website, so you can watch it again. We could probably have AI write up a quick written summary of it with images as well. So yes, thank you for that very much.
And actually, you touched a number of points which are personal. With the previous lecture too, I had exactly the same thing with my kidneys, and I was very fortunate that the doctor didn't operate my kidneys for cancer, but it took a biopsy and discovered that I had IgG4. So that's a perfect example. And the other thing which is interesting is I did have all sorts of symptoms that you're speaking about long time before I was discovered that I have IgG4.
You had the symptoms for a long time. Yeah, that's typical. It's not a fast-moving disease, and that is its danger, because it flies like a crow through the night, and no one knows it. It goes for months or years, and then it's causing damage all the time, and people don't even know that they're sick. Michael.
This is not exactly what you've been just talking about, but you said any questions, fair game.
Any question.
How can one disease present itself so differently? Is there any progress being made on that biology, how all this happens?
Oh gosh, I would be in Stockholm if I knew the answer to that question. We don't know. I mean, it's this disease, I'm a rheumatologist, and Dr. Kay's a rheumatologist, and Dr. Baker's a rheumatologist, and we deal with oddball diseases all the time. And this one is the oddest of them all. It's the most protean. It can do so many different things. So why does it choose to cause kidney disease in some patients, pancreatic disease in others, retroperitoneal fibrosis in others? The organ, the predilection remains a complete mystery, unfortunately. However, with the pace of science, I do think that we're going to get to some of these answers. I'm disturbed by the current trends in NIH funding and the impact that that may have in our advance in understanding this disease. But I think that we've made such remarkable progress, we're going to be able to get to some of these answers before I retire. And I'm not retiring anytime soon. Yes. Yes.
Hi, my name is Mike Jacobs. I'm newly diagnosed and have, they're setting up rituximab for me. Now that I've heard you talk about the other drug, I'm thinking, do I need to ask about that one instead?
Well, I'll tell you what I tell my patients. If I had to decide how to treat my brother, whom I love, I would use INEB. As I said, it's a humanized antibody, so it's less likely to cause these infusion reactions and serum sickness. It may be more effective. It depletes a broader swath of the B cells. CD19 is present on more B cells than CD20 is. So INEB, at least in theory, may be more effective.
And it could be, I'm being treated through the VA, so I don't know if they have access to that.
Well, one thing I certainly don't know is who's going to be approved for what medication. And okay. I don't know how the VA would approach that.
Okay. And another quick question on shingles. And actually, your patient, Mrs. H, I mirror her. Okay. In my symptoms and everything that's going on. So that was enlightening too. But I had shingles 10 years ago. Okay. I have not had a shingles vaccination. So it sounds like I need to get that before.
I think you should. Okay. Yeah, you should do that. Okay. Yeah. But good news. I used to be, when I started off on this track, I used to think that patients like you were going to have stents in forever. We'd never be able to get them out. The first cases looked, just hopeless. But these therapies are very effective. And we treat patients, and sometimes the fibrosis doesn't go away completely radiologically. Sometimes it does. But we get the stents out, and people have normal lives in a very high percentage of patients. So keep the faith. Yes.
Dr. Stone, I want to just take a second for my question and just say thank you from all of us for your dedication of your career to IgG4 related disease. And Dr. K, a lot of us wouldn't be in this room if it wasn't for you and Dr. K, and we want to thank you very much.
Thank you.
Mrs. H, you said she had RPF, retroperitoneal fibrosis, but you never mentioned IgG4 related disease in that. And yet you treated her with INEB, which normally I think, don't they say to do rituximab, because that pertains more to the CD20 rather than the CD19. So I have RPF, I have not had a biopsy, so I don't know whether it's IgG4 related or RPF.
So that's a great question. And it gets to the point that there's a lot of unmet medical need in RPF, and that relates to both understanding and how to diagnose it and how to treat it. The distribution of the fibrosis is really, really important in classifying patients as having IgG4 related retroperitoneal fibrosis or non-IgG4 related retroperitoneal fibrosis, to the extent that it's important to differentiate them, actually. I'm not sure it is that important to differentiate them. But there's a classic radiologic distribution of IgG4 related retroperitoneal fibrosis, and that is around the aorta, a peri-aortitis, and then often down in the iliac blood vessels, that's where the aorta splits, bifurcates to go provide blood to the legs. And if the inflammation is around those areas, then it is almost certainly IgG4 related disease. And that distribution explains why so many patients with IgG4 related retroperitoneal fibrosis develop hydronephrosis. And that's because the ureters, as they come out of the kidney and they make their way to the bladder, they cross the iliac arteries, and that inflammation traps them, and hydronephrosis happens, and patients get flank pain, just as I think you told me you had. And so that is classic for IgG4 related retroperitoneal fibrosis.
Is that considered attacking the kidney, even though it's...
So the question is that considered attacking the kidney? No, it's not attacking the kidney directly. It can damage the kidney because the hydronephrosis and the backup of urine damages the kidney. It can lead to failure of that kidney. But that's different from IgG4 related disease involving the kidney directly. There is IgG4 related disease that involves the kidney directly, and I know many patients in this room have it. And that pathology there looks just like the pathology in retroperitoneal fibrosis, which looks just like the pathology in the pancreas, which looks just like the pathology in the extraocular muscle. So it's a different presentation of the same disease. And getting to Dr. Bamber's question about how this disease can do so many things. Yes, Bob.
Good to see you as always. Is CAR T therapy still being considered as a viable option?
Yes, CAR T therapy, this is a cell-based therapy. It is when one takes often a patient's own T cell, but sometimes it's not the patient's own T cell, reprograms it to kill B cells. And it's being used in a lot of different kinds of diseases now, in lupus, in ANCA-associated vasculitis, and it's been used a lot in cancer. One of the trials that is beginning soon, I mentioned ACE 1831. It's a trial that's beginning very soon at our center and others. It's not a CAR T therapy, but it is a cell-based therapy, so to speak. I do think that these therapies are going to have a big impact in the reasonably near future. For the CAR T therapies, I think it's a matter of getting up our nerve to use the therapies, because they do work very well, but there are more risks associated with administering the therapies than our conventional therapies are. Thanks. Yes. Dr. Bamber, this is Linda Bamber.
Well, my better half asked the big intellectual questions. I'm here to ask the practical questions.
Okay.
If one is on B-cell depleting therapy for many years, are the side effects of the therapy cumulative over time? Or is the fact that he is getting sepsis, MRSA, skin cancers out the wazoo, is this just because, he's another 3 years older? Or because he had no problem until about 2 years ago.
Mm-hmm.
So, and if these effects are cumulative, is there anything coming down the pike for any other patients who may be having, a long series of infusions?
Okay, great questions. So I think the answer, there are really two parts to the answer. I mean, one is that the side effects of B-cell depletion are cyclical by and large, and when the B cells are gone, patients are at risk for certain kinds of side effects. When the B cells come back, they're not at risk for those same kinds of side effects. So I don't think that the risks are cumulative, but they're really cyclical. Will there be other things? Absolutely. I mean, it's a huge leap to be able to not use prednisone. That's a huge leap. And IgG4-related disease is one of the very first diseases in which we, in many patients, can get away without using prednisone. And that's another question altogether. I mean, some patients will do fine on prednisone and has to be monitored very carefully. But by and large, prednisone is used incorrectly, in the broader world, and patients are at great risk for side effects. So it's a huge thing to not have to use prednisone if we don't have to. The next thing will be not having to use B-cell depletion and to have more elegant mechanisms of tinkering with B cells so that we don't have to leave patients B-cell depleted forever. Or to use these B-cell depletion therapies more wisely. Maybe don't use them every 6 months. Maybe only when patients need them, and understand better when patients need to be treated again. Dr. Baker will tell us about that tomorrow. Yes. Yes, over here.
Can you talk a little bit about the steroid-sparing drugs that some physicians are recommending over going to do first before the B cell and the effectiveness? And also, if someone has experienced sepsis while being on one of those medications, is there an additional risk or any precautions or way that person could set themselves up to get through the process as healthy as they can?
It's a great question. The steroid-sparing medicines that you mentioned really are what we call DMARDs, disease-modifying anti-rheumatic drugs like mycophenolate and methotrexate and azathioprine. The concept that these drugs are steroid-sparing is largely wishful thinking. They have been used for decades in some cases, but their ability to really spare steroids has never been proven, generally. They seem to be working as long as steroids are on board. You take the steroids away, and it's pretty clear they're not working all that well. And they're not candy. They have side effects. They absolutely have side effects, and that's why I say that B-cell depletion, by and large, is safer than steroids and DMARDs. Now, the other challenges of DMARDs is it's really hard to measure how badly they're impairing the immune system. With B-cell depletion, it's reasonably easy to know. You can know whether the B cells are present or not. You can't measure that so well in a DMARD. And so the side effects can come out of left field and really catch you by surprise.
Thank you.
Thanks. Yes, one more question.
I'm new on the journey here. I haven't started therapy yet. And so far, my profile indicates I have an elevated IgG4 and a depleted IgG2. And therefore, the thought of going on B-cell depletion therapy raises some red flags for me. And I just now heard you allude to the fact that maybe in the future there'll be some therapies that will be more selective in dampening IgG4 and not affecting the other subclasses. How does that stand right now in terms of someone just getting ready to start therapy? Would you still recommend the monoclonals?
Yes, I would. It's a great question. We don't, IgG1 we think about a lot. IgG1 is the most abundant of the immunoglobulins. It's really important in preventing infections. There are some infections that can be associated with subclass deficiencies, IgG2 probably and IgG3 as well. We don't give them too much practical consideration though, honestly, and I wouldn't be too concerned about that. If your IgG2 is a little bit low before B-cell depletion therapy, I would just follow it and I wouldn't be too concerned about it. Thank you very much. That was a great breakout session. Thank you for your questions. So we'll have a 10-minute break now while we move to the other breakout sessions. You can go to any one you like.